Hello everyone, welcome to our module on patient involvement in interprofessional education. While I don't intend on discussing anything too heavy in this presentation, this module can make some people feel very vulnerable because it may cause them to reflect on their own experiences as a patient or a caregiver. Learners also may or may not want to share their own experiences as a patient in our MLC discussions during this module. I am going to share some of my own experiences as a patient during this presentation. And in this module, I encourage you all to make sure that you're being very mindful of your emotional and mental well-being. This is something you can reflect on your MLC portfolio as well, for sure, or you can also reach out to me if you want to do a bit of a debrief after. And as a reminder, Ottawa students have access to free counseling services if needed. So please do make sure you're making use of these services if you feel it's something you would benefit from, particularly after this module. And there's more information on counseling at Ottawa in our syllabus. And as a heads up, I'm not feeling super great today. Normally with these videos, I do practice running through my outline a few times, so I sound a little bit more conversational. I'm recovering from a concussion right now that I sustained over the summer, and today just isn't really a good day. So I'm probably going to be reading a bit more directly from my notes than I usually do. So a brief overview of what we're going to be discussing today. So I am going to talk a little bit about my own patient journey because I've introduced you guys to myself as an academic and as a person in this course, but I haven't really introduced myself as a patient. And not talking about the concussion, though, because that's not a very exciting story. It's really just a classic case of car window versus side of head, and my brain was the loser. Then we're going to talk a little bit more about terminology. For example, patient versus client. What do we call patients who are involved in education, etc. We'll also briefly touch on patients who are also healthcare professionals. Then we're going to dive into patient involvement in health professions education and interprofessional education specifically. And we're going to discuss some questions like what can patients teach, what are the benefits and barriers and risks of involving patients in interprofessional education, and then we'll conclude with some tips for educators. So like I said, I haven't really introduced myself to you as a patient or talked about my patient journey in this class. Even calling myself a patient feels really weird, but I think it does ultimately apply to me. And I'm sharing with this with you to establish my positionality within this module. So I thought I'd share my journey surrounding my hands and my wrists in particular. It isn't the craziest patient story out there for sure, but it's my story. And it's also the story of why I had to leave clinical nursing, so it's had a pretty dramatic impact on my life. So about 15 years ago, I was having really bad pain in both my wrists. There was no particular injury that occurred, but I was doing a lot of activities at the time that put a lot of stress on my wrists, like nursing school, and I had just started Taekwondo. And sometimes I'd have these bumps on the back of my wrists, but not always, and like the pain, they would kind of come and go. But things quickly got worse. I'd have a lot of flare-ups, my wrists would get really easily injured. I couldn't do things like push-ups anymore. And it felt like there was always something restricting my range of motion, especially if I tried to extend my wrist backwards and put any sort of pressure on it. And it often felt like I had a piece of ice lodged in my wrist because I'd get this burning cold pain. And it got to the point where even just assisting patients with things like breastfeeding was so painful that I would sometimes slip out of the room saying I had to quickly go check on another patient. But I'd actually go into the dirty supply closet so I could massage my wrists and sometimes cry because I was in so much pain. It got to the point where even just things like pushing on the bar on the bus door to open the door to the bus could have my hand in a splint for a week. And it felt like I was constantly just swapping between hands for which one was in a splint at any given time, because as soon as one seemed to be well enough to take the splint off, the other one would be injured due to overuse. I even learned how to write with my left hand so I could give my right hand a break at times. And getting a diagnosis was really difficult for a variety of reasons. For example, initially not having a primary care provider, moving provinces, and the fact that the bumps would come and go so much. So often my wrists would look normal by the time I was actually able to get in for an appointment. So I had figured out my ultimate diagnosis back when I was in nursing school. It was ganglion cysts. I had seen them a lot in the clinic when I was practicing as well, and I had done a lot of readings on different types of wrist issues, and this just really seemed to fit my symptoms best. Basically, they're just little fluid-filled lumps that can just pop up sometimes around joints and tendons, and they can grow or shrink in size, which explains why my bumps weren't always there. But I had a hard time getting anyone to listen to my suspicions or even entertain them in the slightest. In retrospect, I think what threw off a lot of healthcare providers, these cysts don't always present with pain. And the lowest part of my journey was when I was referred to a physiotherapist who didn't listen to me at all. I told them I was a nurse at that point, hoping that I would be taken more seriously. But as soon as they heard I was a nurse, they assumed I'd had a workplace injury, and it was just scar tissue buildup. And they wouldn't listen to me, and they dismissed me when I said that their treatments were just unbearably painful, and they didn't seem to be helping at all. And one day I almost passed out during a physio session, and at that point I was done, and I stopped going anymore. And in retrospect, they probably caused a lot more harm long term. I finally got a diagnosis once I went into research, probably 4-ish years after I started having the pains. The vice dean of the office that I worked in happened to be a hand surgeon, which is very lucky. And he barely even had to look at my wrists before he was like, oh yeah, those are ganglion cysts. So he had me get referred into his office. And I had a really hard time not crying in that moment. I was just so relieved because for once I wasn't dismissed and I was finally going to get some help. I was also incredibly frustrated because the right care provider had no difficulties in diagnosing me, and I'd been living in pain for 4 years for nothing, it felt like. And then I was also frustrated because what about other patients in similar situations who didn't have a background in nursing and could advocate so well and who didn't have connections like this in medicine? So I got my referral into the hand clinic, no problem. Fortunately, my cysts had to be taken out surgically. Sometimes they can just aspirate the fluid out of the cysts, but that didn't work for me. I also developed a heart arrhythmia shortly after the first surgery, which no idea if that was related or not. And that's a whole other story. But eventually I was cleared to have surgery on the other side, which was great. Unfortunately, the cyst on my left side came back after a few months, so a couple of years later I had to have a second surgery, smack in the middle of my PhD coursework. Some of my profs were really great about offering accommodations, and others really weren't. So ultimately, the final theory on what happened was my cysts got stuck under the tendons, which is why I didn't always have the visible bumps despite being able to feel something being in there. And they were pressing up against structures in my wrists, which was what was causing so much pain. Apparently, according to my surgeons, my cysts also hardened. And all this has costed lasting permanent damage to my wrists. I can do a lot more now, like I can bend my wrists back, which I couldn't do before, which is exciting. And I'm working on improving my grip strength, but my wrists are still really easily injured. Like a couple months ago, I hurt myself just twisting open a doorknob, and last month I had my wrist in a splint for well over a week after just picking up an empty photo album. There's also things that my husband has to do for me around the house, like scrubbing the bathtub and opening jars because I can get injured pretty easily from activities like that. And I also have to use a specialized mouse and keyboard so I can do any work on the computer. And it took me quite a while before I trusted anyone beyond my surgeons with my wrists. And even now, I'm very cautious of healthcare providers who I don't already have a really good rapport with in terms of handling my wrists. But we've gotten to the point in the last few years where my care is managed pretty much entirely by a team of chiropractors and physiotherapists and massage therapists. Who exactly I need to see at a given time depends on what's going on. And having an interprofessional team that actually communicates with one another and treats me as a member of the team has made such a difference in my care. I feel heard for once. And it's really easy for us to be able to shift our approach and who I need to see as needed depending on whether or not my wrists are behaving at any given time. So let's delve into terminology and discussing who are patients. As I'm sure many of you are aware, different professions may use different terminology when they are talking about recipients of healthcare services. This can vary depending on areas of practice, both in terms of their specialty, so say public health versus surgery, and it can also vary depending on geographical region as well, because different areas may use different terms. For example, standardized patient can mean many different things depending on the context. And on the screen here is a word cloud that I generated with some of the different terms that I came across while I was looking at the literature. So for recipients of health and social care services, I found patient, client, community member, even service user. For patient involvement, I also saw user involvement, service user involvement, consumer/lay partnership or participation, and patient participation. And for patient involvement, specifically involving teaching, I saw patient educators, instructors, mentors, partners, teaching associates, and community educators. And our Reading This Week by Rom et al. 2020 refers to them as experts by experience, which I also found in some other articles. And this certainly isn't an exhaustive list of all the different synonyms for these terms, but it just kind of gives you a taste of how terminology in this area isn't standardized. And the new CIHC framework for collaboration, which I'll talk about a little bit more further in this presentation, proposes using persons instead of terms like patient or client in the framework. And the rationale highlights some of the controversy that surrounds terms like patient and client. So patient being problematic because it does imply a power dynamic, and client being problematic because it implies a commodified relationship. And that's a concern I've also heard raised from some physicians in my career as a researcher. So the framework proposes instead using person or persons, which is what they use in their framework, to refer to any individual, group, or population who participates in and benefits from health systems and services as co-producers of their health. And I want to pause here for a moment for you to reflect on a few questions. So what terms does your profession use to label the people who are seeking out health, wellness, and social services? And what might these terms imply about your profession's relationship with them? How do you feel about the term person or persons to describe people seeking out health, wellness, or social services? And what do you think about reframing patients or persons as co-producers of health? And what could that imply for interprofessional education and practice? So in my own reflections, I do really like the idea of using the term persons or persons in theory. It is certainly more humanizing. But I do have a couple of concerns about it, mostly from a research standpoint, I guess. So first and foremost, as a researcher, I think this could make it difficult, or more difficult at least, to find literature on topics like patient involvement and patient education and patient outcomes. If the articles were to fully replace terms like patient, client, and client with persons, person would just bring up so many more irrelevant articles in a search, and it would make it actually much harder to access best evidence on these topics. And then my second concern, I guess is just more of on a personal level, is that I find it kind of confusing. Reading through the CIHC framework was a little bit confusing because realistically, members of the care team are persons too. And so this caught me up several times when I was reading the framework, and I had to reread some sections to figure out what it was trying to say. This could be just entirely, though, because using this term instead is new to me. And having a background in nursing, I'm pretty heavily socialized into using the term patient. So I think the really key piece here, though, with terminology is being critically reflexive about the terminology we use, why we use it, what it might imply, and how we can address these sorts of issues in our practice as clinicians, educators, managers, researchers, etc. But this is all just purely my personal opinion. You are more than welcome to disagree. For this presentation, I'm going to stick with the term patient. A lot of articles also continue to use the term patient for the sake of clarity, while also acknowledging some of these potential issues with the term. And for your assignments in this course, I am fine with terms like patient, client, community member, person, etc. So long as I know who you're referring to and you're not using derogatory terms or something like that, it's all good. So the other point I wanted to touch on here is health and social care professionals as patients. Sometimes when we're thinking about how to understand and teach the realities of healthcare, we may think of health and social care professionals and patients' experiences as two separate, different, unique perspectives. And these perspectives can be seen as binary. As Rowland and Cooper 2018 point out, we're either patients or we're providers. And sometimes this division can be clear, but sometimes someone can fill both roles. And throughout the literature, this is often described as being on the other side of the bed rail or on the other side of the stethoscope. And these patients, who are both patients and providers, can be great informants for understanding the healthcare system and practices. And that's not to say that other patients are any less credible or they're not important. Rather, it's just that patients who occupy both roles can offer us some pretty unique perspectives because they have been in both positions. However, this group can also face some unique challenges. And here's a couple to keep in mind as educators, researchers, and health and social care professionals who are likely to care for a fellow insider at some point. So they can experience insider vulnerability, where the care team's assumptions about their knowledge may mean they aren't being given enough information or compassion. And I wanted to add here that enough information also means making sure that they understand the information. For example, when I was doing my obstetrics rotation way back in the day, I cared for one of our OBs postpartum, and she'd had a pretty significant hemorrhage in her birth. And so when her blood work came back, I told her what her hemoglobin level was because she was curious. But then she paused for a second, and then she asked me, wait, what's a normal hemoglobin level again? So don't make assumptions that they remember everything, or that they know the routine and procedure, or that they don't need compassion just because they're a healthcare professional. It's a totally different experience when you're a patient. Another risk that they might have is they may be less likely to let their healthcare team know about their needs. And there's also complex boundaries to be navigated here between their role as a patient and a healthcare professional. They obviously can't be diagnosing themselves and prescribing and things like that, of course. But ignoring them, which we'll come back to in a moment, can be very upsetting. And some patient providers may not identify as a patient. Like at this point, realistically, I've been on the patient side of the bed rail for longer than I was a nurse, but I still struggle a lot in patient scenarios because part of my brain is still like, no, I'm a nurse, I'm not a patient. Healthcare professionals can also feel very powerless as patients. There can be also enormous implied pressure for them to be a good patient or for them to be a good teaching object for students. And finally, the decision to even disclose they're a healthcare professional can be a very calculated decision based on the perceived consequences of doing so. For example, it may be done to give them more space to speak up, or it may be done as an attempt to pull rank because they're feeling helpless. Patient providers may also worry about their concerns being dismissed, where the risk of being ignored becomes even more painful if one feels ignored both personally and professionally, which is something I have absolutely experienced as a patient, particularly with that first physiotherapist I saw about my wrists. So now that we've talked about kind of patients in general, let's switch gears and talk more about patient involvement. So while we're going to be focusing really more on the educational side of patient involvement today, there is, of course, an element of this within just normal clinical practice. Increasingly, we are looking towards patient-centered care and reorienting the focus to the person rather than the clinical issue, and involving patients as co-creators in their care. And the involvement of patients or persons and care partners, for example, family members, loved ones, is all weaved in through the Canadian Interprofessional Health Collaborative's new competency framework for advancing collaboration, although it is, of course, also discussed in the previous version. So the framework calls for us to work together to foster purposeful relationships among all members of the interprofessional team, including the person receiving care and any care partners they may have, for example, family members. And part of this is ensuring that patients and their care partners are supported in being full members of the team and across all stages of their care. But what does this mean to us as educators, and how do we involve patients then into their teaching? And before we get into that, I want you to pause for a moment to reflect on your own practice and your own education as well, and how it relates to patient involvement. So how are patients involved in your education or the care teams in your organization? How has your socialization into your profession influenced how you think about the role of patients in the healthcare system, within interprofessional teams, or within health professions education? Historically, learning that involved patients was more so to illustrate disease. A patient could find themselves being wheeled into a lecture hall to act as a teaching aid, regardless of whether or not they consented. And we can see what this looked like here in this image of a patient in bed in the middle of a lecture hall. So historically, patients were very much passive agents rather than being actively involved in teaching, and they were more so a teaching object, unfortunately. So what does this mean when we're talking about patient involvement in education? Well, I thought this was a pretty good definition of what we're discussing today. So here they defined this as the active involvement and engagement of patients in the education of future healthcare professionals, both formally and informally, in all sorts of roles, using their unique experiential knowledge of living with disease, illness, or disability and receiving healthcare. Now, the only part here I personally would take out for the purposes of our discussion today would be the part about future healthcare professionals, since I think we can realistically include patients at any stage of our learning. For example, it could also include residency education or even continuing professional development. So let's talk about some specific aspects of this definition, starting with their unique experiential knowledge and what that means they're able to teach. So in short, really here is that what we can say is that patients have a wealth of experiential knowledge from their own lived experience. For example, experience of illness or disability, experience with the impacts of social determinants of health. And because of this, they may become experts by experience. And as mentioned earlier, traditionally patients have had more passive roles in health professions education, but they can absolutely take a more active role in HPE. And there are a number of different topics that they can teach about. For example, communication. This could be patient-provider communication, or it could be broader within the context of an interprofessional team. It can teach other interprofessional skills too, like collaboration, technical skills like physical exams, quality of care, which I think is very much related to our last two examples here. The first being that patients can teach us a lot about what we often won't find in textbooks. For example, the experience of living with a disease, illness, or disability. And wanting to share their experience about this can be a reason why someone may want to become an expert by experience or a patient educator. And empathy. In FAIRY 2023, it talks about how involving experts by experience or patient educators in IPE can help health and social care professionals have a more empathetic and holistic understanding of the patient, stressing treating people and not diseases, because it helps learners put themselves into their patient's shoes. And something that the dean of my nursing program used to always say is, you aren't treating diabetes, you're treating a person whose pancreas just doesn't want to play the game. And through learning from patients, health and social care professionals will also learn skills surrounding patient-centered care. And our reading this week had some really great participant quotes as well. So in this quote, an applied science student reflects, "You really learn how to empathize. In our education, we learn all about diseases and their respective treatments, but we do not learn what is accompanying this illness, what is going on in the person. That is what I learned in this module. That's very important." And in this quote, an expert by experience reflects on the lack of empathy that they've received in the past from physicians. They, the doctors, are robots. They have much knowledge, but that's useless if you do not have much empathy. I see it as my task as an expert by experience to train the doctor. And helping health and social care professionals learn empathy can also be a big motivator for patients to become educators. And the decline in empathy amongst physicians, at least specifically, has been linked to worse patient health outcomes and physician burnout. And if we return back to our definition again, the first half of this definition indicates that this involves active involvement in all sorts of roles. So what does this look like? Our reading this week lists off a few examples of how patients might be involved in IPE, such as paper-based case studies, simulated patients, or involving actual patients in our IPE. And here's some further examples that I found specifically within the IPE literature. So very commonly, patients are brought in as guest lecturers. This could be in a large lecture hall, or it could also be in smaller groups. For example, Ferry et al. 2024 had patient educators share their disease experience to an interprofessional group of students, who then reflected on the patient and caregiver roles within the healthcare team, as well as some best practices. Patients may also be brought in to co-facilitate small learning groups. For example, when I used to work as a volunteer at U of T's Center for IPE, one of the workshop series I facilitated was one where we had patient educators in small interprofessional groups. I think it was called the Health Mentors Program. And within this program, I helped co-facilitate a workshop series where a patient came in to share their health journey with an interprofessional group of students. So part of it was her presenting, but it was also very interactive, and the students had many opportunities to ask questions. And then the students had a couple of weeks to work on some stuff with each other online. I think it was developing a care plan before we all met together again with the patient. So this was far more interactive than just a guest lecture. Our reading this week also talks about a multi-session learning module that was facilitated by experts by experience. We can also have more longitudinal involvement like this. For example, also interviewing patients can be a really good way of integrating patient educators into HPE more broadly. Patients can also be involved in IPE by providing feedback to students. So for example, in Jensen et al. 2024, students completed an interprofessional clinical placement where they were on an interprofessional student team providing care for the same patient. And the patients also talked in the article about the process of providing feedback to the students. And in HPE in general, patients can be a really great source for feedback since they observe so much of our learners' practice. So in HPE, and I would extend this to IPE as well, we can also explore additional roles for patient educators in our curriculum. For example, assessment, like I mentioned above, as well as things like curriculum development. And I found this great table in the literature that lists off varying degrees to which patients can be actively involved in a learning encounter. So it starts off with lower degrees of involvement, like case studies and standardized patients. And from there, the involvement becomes more active with sharing their experience and moving through various levels of involvement in teaching, evaluation, curriculum development. And then patients can also be involved at the institutional level and also in more sustained teaching positions. And so before I talk about some of the benefits and barriers and risks for patient involvement in HPE and IPE, take a moment to reflect on this yourself. So what benefits do you think there are to involving patients in HPE and IPE? What kind of barriers might hinder involving patients? And if it helps, you can think about this in terms of the PROC framework. And what risks might be involved? There are a number of benefits to patient involvement in education. For example, the development of student skills like patient-centered care and professional skills. It can also help develop interprofessional skills. Specifically, for example, learners might learn more about another profession's scope of practice and responsibilities through seeing the types of questions that they're asking patients. It can also just make education more engaging, and it helps contextualize what health and social care professionals are learning about. It also helps learners become more empathetic toward patients. And patients and professionals might also have different perspectives about what constitutes quality of care, which can be really explored through involving patients in education. It can help overcome prejudice, stigmas, and stereotypes. For example, it might help learners develop more positive assumptions and attitudes towards people with chronic illness. It may shift power dynamics and empower patients. Just feeling heard through sharing their experience can also feel very therapeutic for patients. Involving patients means our education may become more responsive to actual patient needs. And ultimately, patients are the end users of teaching in health professions education. So we should be consulting them while developing our curriculum in HPE. Many patients may also find it meaningful to contribute to health professions education. And there could be a lot of potential barriers and challenges when it comes to involving patients in IPE and HPE, although that's not to say it's not a worthwhile endeavor. So I approached this issue through the PROC framework when I was putting together this presentation because there was just so many different ideas for me to sort through. So I started by considering really the patient as a member of the interprofessional team within the center of the PROC framework, and then kind of consider this all in relation to interprofessional education. And this is ultimately what I came up with. This is by no means an exhaustive list, and some of the barriers, realistically, I had a hard time slotting them into one of the 4 places of the framework because realistically they kind of overlapped with more than one factor. But yeah, this is basically what I came up with. So for relational factors, patient-provider hierarchies and power differences. And related to this is also how challenging it can be for educators to let go of the idea that they are the experts to make room for patient experts in their teaching. Because patient educators or experts by experience do challenge these power dynamics and our understanding of expertise. Hierarchy in academia can be a barrier. Both the patient and facilitators might need some additional training as they start to adjust to their roles. And there can also be some conflicting or clashing goals between patient educators and faculty member educators. For example, a faculty educator has learning objectives and academic goals, whereas the patient may have a more therapeutic goal as well in mind for themselves. There's also processual factors, so time constraints on faculty educators. And at the end of the day, ultimately, faculty educators really are the ones who are still maintaining control over the learning and the curriculum. So they also get to determine who gets to be a patient educator. So ultimately, they're deciding whose voices their learners get to hear. And varying curricula between different professional groups can make involving patients in IPE challenging. And it can be really difficult for faculty to juggle ensuring that the IPE learning outcomes are met while also ensuring that there's that space left for the patient to be seen as a whole. There are a number of organizational factors, like payment for patient educators, funding and financial constraints, lack of organizational support, and this can include lack of support for patient educators and then also lack of support for the faculty educators who are trying to implement this. Accreditation processes can be a barrier, and as can just general organizational changes. And then finally, there's contextual factors like different definitions of knowledge and what's considered evidence, stigmas and discrimination, academic culture broadly can also be very individualistic and hierarchical, which can serve as a barrier. And hidden curriculum can also undermine the formal curriculum regarding patient involvement. For example, promoting a very narrow medical focus on patient care at the expense of empathy. There can also be some potential risks to experts by experience or patient educators that we need to be mindful of as educators. So being an expert by experience can make patients vulnerable, and their experiences surrounding their health journey that they share can be quite intimate and painful. And there can also be a risk of dehumanizing patients if they start to be seen as a learning objective. For example, an object to learn a skill on rather than being seen as a partner in teaching and learning. Patient preferences, especially in clinical settings, might get neglected. There can be a risk of stigmatizing patients, and there can also be risks if we don't ensure their confidentiality. And our reading this week also talks about how experts by experience or patient educators in their study misunderstood students being interested in them and their story as the students being interested in pursuing a friendship beyond the learning modules. So these professional boundaries still need to be maintained, and the experts by experience and your learners need to be aware that this contact between them is temporary. So patient involvement in IPE can make them vulnerable, and it does come with some risks, but that's not to say we shouldn't involve patients. We absolutely should. And as educators, we need to provide these patients with support before, during, and after the educational activity. So some tips for patient involvement in HPE. So since I talked about tips for IPE in general last week, I'm really going to focus more on the patient involvement piece here this week, so I'm not repeating myself too much. And these 12 tips I found in this article are great. Some of them are, though, a bit more organizational and beyond what people in this class do more in their day-to-day work and teaching. So I'm going to highlight a few key takeaways from here and from some other literature that you can address in your workplace, although I do recommend checking out this article. It's pretty good. So my tips for educators. First one is let it go. Let go of traditional ways of teaching and share control of learning with patient educators. And for those of you who are in the role, like me, where you educate other educators, this might involve teaching others new teaching strategies and how to collaborate with patient educators. Create a courageous space. And this is a phrase I got from Dr. Awad Abraham here at UOttawa, but I think it applies here. So seek to foster a learning environment where it's safe for patient educators and students to be vulnerable. And one way you can do this is by being vulnerable yourself. Start early. So for those of you in pre-licensure training or even PGME, start involving patient educators in programs early on and have your learners reflecting on these encounters with patients so this becomes very normalized to them. Go beyond patient lectures. Patient lectures are great, but also consider other ways you could potentially integrate patient perspectives. For example, it could be more longitudinal involvement in mentorship programs or interviewing patients about their experiences. You could also consider different roles for patient educators in your curriculum, like assessment and curriculum development. And it can be beneficial to actively engage patients across the process in developing and implementing an educational intervention. No matter what their role is, provide patient educators with support before, during, and after an educational activity. Have a good briefing with them before to discuss their preferences, what they can expect, and how you are going to support them during the event. And then debrief with them after to see how you can adjust future learning activities like this. If you're in an academic setting, it might be beneficial to give them a little briefing on the academic world. And you might also need to provide some training with them prior to the role. For example, surrounding their role responsibilities and what exactly the learning objectives are for the session. But it's also important to remember here that we're trying to support them in sharing their perspective and experience. We aren't just trying to make them fit into the mold of a traditional lecturer or a professor type role. Likewise, make sure you're supporting your students. Provide them with support in reflecting on their experience and learning with the patient educator, and also be prepared to help them process possibly emotional encounters. Furthermore, some of them might have their own experiences that have commonalities with the patient's experience, either as a patient themselves or as a family member or a friend or caregiver of a loved one. Like we discussed earlier, health and social care professionals can also be patients themselves. So ensure your learners know ahead of time that you might revisit some potentially painful personal experiences, and make sure you have a plan for aftercare should this occur. And speaking from my own experience, sometimes these things affect us in really unexpected ways. So like I had a few years between leaving clinical nursing and finding myself in a hospital as a researcher. And during that span of time, I had my first 2 surgeries. So my experience of hospitals and clinics during these few years was very different. And my first time back in an OR, I was watching orthopedic surgery as part of a study on the surgical safety checklist. And I had to leave for a few minutes and go lie down on a stretcher because I thought I was going to pass out. And it's not like it was the first time I'd seen a surgery or anything like that. But it was my first time having seen one since I'd been on the OR table myself, and I saw the whole procedure through a completely different lens than how I used to see it as a nurse. So support your students and yourself in case something is upsetting or painful. Incorporate critical reflexivity. So while some of your learners may indeed have some patient experience, not all of them will. But we can help our learners become more empathetic and better healthcare professionals by teaching critical reflexivity about power, hierarchy, systemic barriers in healthcare, so our learners can identify and address these issues that can limit compassion for patients. And this is just really important in general, even beyond interprofessional education. For example, when teaching the non-medical expert CanMeds roles in medicine, for example, how can we realistically be teaching things like being a health advocate if we don't talk about power and hierarchy and hidden curriculum? And I want to add here that it shouldn't take an upsetting personal experience for someone to develop more empathy or concern for patient-centered care. This is something that we can address through our education. Not all patients are the same. For example, acute versus chronic illness, language, culture, gender, race, sexuality, socioeconomic status, the list goes on. So try to make sure there's some diversity in the patient educators that are involved in your program, and consider if a certain group or groups are underrepresented. People living in poverty, for example, are often underrepresented. Have a holistic mindset. So a patient's journey is complex. It's more than just a disease or a focus on specific specialty groups. So try to look at the patient as a whole person, and this will open you up to whole new perspectives, as well as breaking down those traditional silos between different professions and specialty areas within them. And ensure the relationship is reciprocal. So discuss with potential patient educators or patient organizations that you may be connecting with what their goals are. Why do they want to participate? And also make sure you're showing appreciation. And this might look a little bit different depending on the program level of involvement and the patient's circumstances. It may be monetary, like paying them or gift cards, or it could be a thank you letter. And I think those tips are a good place to wrap things up for now. In my next video, I'm going to talk more about considerations for Indigenous-led partnerships. Please let me know if you have any questions about patient involvement in IPE or HPE more broadly. And as always, I will see you all online.